Ladies and gentlemen, welcome to Cardiology Lectures. I am Dr. Nik Nikam from Houston, Texas. Today we are going to be going over a quick review of how to evaluate a cardiovascular patient. If you're a student, if you're a first year resident and you're starting for the first time, I'm going to give you some quick overview of what are the things we look for in cardiac patients. Before I get started, I would like to introduce you to my cardiology rotations manual, which you can get a free copy of it, and I will tell you at the end of the presentation how to get this copy. And here we have almost 140 pages of chock full of information for evaluating and managing cardiovascular patients. So let's get to the point where we want to go. Cardiovascular exam, you can press control click and it brings us to cardiovascular exam, and I want to start off with history and physical examination. Some of the pertinent things we ask in cardiovascular patients in general. I just did a video on taking particular history in patients with decompensated heart failure. You can watch that one. Here we're going to be focusing on overall general cardiac history and examination and looking at the lab studies. And in the next presentation, we're going to talk about how to evaluate a patient with chest pain, acute coronary syndrome, or acute myocardial infarction. So let us begin with how do we approach a cardiovascular patient if this is your first time rotation. First thing I would do is go through their electronic medical records and document every kind of cardiovascular events they had. Did they have coronary artery disease? If so, did this patient have myocardial infarction? Did this patient have cardiac catheterization? Did the patient have coronary artery bypass surgery? How many stents did this patient have? When was the last time the patient had a stress test? When was the last time the patient had an echocardiogram? What is the left ventricular function? You need to document all these as a block in the past history so that you have a better understanding of what you're dealing with before you even go and talk to the patient about their symptoms. Does the patient have valvular heart disease? Does the patient have cardiac arrhythmias? Does the patient have pacemaker? When was the last time the pacemaker was checked? So anything and everything you can extract from the electronic health records and compile them into 2 to 3 paragraphs. Now, chief complaints. Don't make a list of 17 different chief complaints. We are doing cardiology consultation. We're interested in maybe 2 or 3 main symptoms. This 67-year-old person presented to the cardiology service for evaluation of chest pain. This 43-year-old patient presented with a history of palpitations. This 68-year-old renal patient presented to the emergency room with worsening shortness of breath. That's the main symptom. So you make sure you have no more than 2 to 3 chief complaints. The patient may have chest pain, shortness of breath, and swelling. All those 3 are very important. Or a patient may have palpitations, dizziness, and history of syncope. All those are important symptoms we need to document. Then the main thing is 95% of the time we see patients with cardiovascular disease, namely coronary artery disease. So we're going to focus heavily on evaluation of coronary artery disease or its differential diagnosis. If the patient has chest pain, we need to fully document what the chest pain means. How long did he have the chest pain? Where is the chest pain located? What is the quality of the chest pain? What is the intensity of the chest pain? Does the chest pain come on suddenly or does it come on gradually? Is the chest pain related to exertion? Is the chest pain relieved by rest? Is the chest pain relieved by food? Is there anything that makes your chest pain better or worse? How long does your chest pain last? How far can you walk before you get the chest pain? Can you walk to your mailbox? You have to have what I call objective symptomatology. So the patient is giving you symptoms, but as a doctor, as a student or a nurse or a cardiologist, you need to translate them into measurable quantifiable symptoms. How shortness of breath. How long did you have this? And what brings on your shortness of breath? These are all typical questions. So in the first part with chest pain, I told you, you want to quantify their symptomatology. So when you're talking to your attending or somebody else, they can imagine exactly what this patient is having based on your description. The patient gets chest pain walking to the mailbox or walking 100 yards. That is much more meaningful than saying the patient gets chest pain with mild exertion. What is the definition of a mild exertion? Think about it. Same way with shortness of breath, quantify it. The patient gets shortness of breath walking from room to room. The patient is short of breath just sitting on the couch. The patient wakes up in the middle of the night with shortness of breath. That's paroxysmal nocturnal dyspnea. The patient shortness of breath came on suddenly, which may suggest an acute infection, pneumonia, pulmonary embolus, cardiac arrhythmia, any number of things. So the onset is important, the duration is important, the progression is important, and we had to see what things made worse. Palpitations, same story. How long did you have the palpitations? Are you taking any medications? Do you have any history of cardiac arrhythmias? And did the palpitation come on suddenly or did it come on gradually? And have you done anything differently as far as your medications are concerned since you had this palpitation? So in that way, you focus, just don't write down patient had palpitations for 2 days and that's it. What else? That's all the patient said. This is a typical answer we get. I say, did you get the quality of the chest pain? So, no, the patient didn't give me any more different qualities. So you as a doctor is supposed to extract all those things. Then we're going to take a history of smoking, which is very important. Again, dyspnea, dizziness and syncope. You precisely have to document an episode of dizziness. What comes on? What are the pre-monitory symptoms? What happens after the dizziness goes away? How long does the dizziness last? What brings on the dizziness and what makes it better? Same thing with syncope. Did it come on suddenly? Were there people around you when you had this blackout? How long did you back out? Palpitations. Palpitations means cardiac arrhythmia. So you have to document what kind of symptoms this patient had. Is this a regular palpitation or is it irregularly irregular? Means it could be like atrial flutter or fibrillation. Frequency, duration, intervals, associated symptoms like dizziness and weight is a very important point for cardiovascular patients. Gain in weight, loss of weight. Has there been a significant change in weight over the past month, 2 months, 6 months? And as far as legs are concerned, any peripheral edema, claudication for patients with peripheral arterial disease. Then we look for risk factors like hypertension, diabetes, chronic kidney disease, hyperlipidemia, and we calculate the CHAD-VAS score. We need to look at precipitating factors like ongoing myocardial ischemia, indiscriminate diet intake, medications mismanagement, infection, volume overload, and all the other things that go along with those. Physical examination, of course, we check for the pulse, we check for the blood pressure, respirations, we look at jugular venous pressure. This is going to be a separate talk on how to examine the jugular venous pressure and carotid pulse. So you check for the carotid pulse, you listen to the carotid bruits, and then you look for any thyroid enlargement, listen to the lungs for any evidence of consolidation, rales, rhonchi, or wheezing, which will give an idea as to whether this patient is having cardiac or pulmonary issues. Cardiac examination. I did a whole video on listening to heart sounds, and you can watch that video. And I also talk about the various heart sounds, namely S1, S2, S3, and S4. And there's a separate video on cardiac murmurs. You can watch those videos. That will give you a tremendous amount of information as to how to put all this clinical examination together with the history. Then you check for abdomen, for hepatomegaly, ascites, and you look in the legs for edema, skin discoloration, cellulitis, gangrene, and check all the peripheral pulses. It's important to document all the peripheral pulses. You look at the skin temperature, and you also make a note of the general appearance of the patient. This 65 years old frail elderly lady. Your one sentence description should give the attending as what exactly the type of patient you're talking about, compared to a 65 years old morbidly obese male sitting in the chair with moderate shortness of breath, cyanosis. He's on oxygen. That's a totally different picture from the first one we presented. So you get the idea. Let's look at some of the lab studies we focus upon. We, of course, look at the CBC count to look for any evidence of infection or anemia. We look at the CMP to look for electrolytes, magnesium. Magnesium is very important. Potassium, magnesium, BNP. Diabetes is important. As we said, diabetes is a risk factor for what is the hemoglobin A1C. Has that been stable? Has that been going up? Then, of course, we check the thyroid, because elderly patients are generally on thyroid pills or they are hypothyroid. I routinely check the thyroid studies. Drug screens you need to do if you suspect any drugs like cocaine, because cocaine can cause coronary artery spasm. EKG, a 12-lead electrocardiogram and a monitor strips are the essential building blocks of history and physical examination and lab studies. You look at the EKG, the rate, the rhythm, any enlargement, any evidence of heart blocks, any ischemic changes, previous myocardial infarctions, and the whole gamut. I have an entire book on EKG clinical diagnosis. All those 12 chapters have been converted into YouTube videos, and you can watch those to get some general knowledge about basic electrocardiographic interpretation. Next, chest X-ray. A lot of cardiologists and most people don't look at chest X-ray. I think that's a bad practice. You should look at the chest X-ray. What is the heart size? What do the lungs look like? What about the pulmonary arteries? Is there any evidence of localized pneumonia? Is there any evidence of emphysema? Is there any evidence of cardiomegaly? Are the pulmonary vessels congested? Is the patient in pulmonary edema? There are a lot of things we can pick up on the X-ray. Are there any evidence of calcifications in the valvular areas, which may signify significant valvular heart disease? The next thing is, of course, the echocardiogram, which looks at the structure of the heart function, and it is excellent for looking for valve dysfunction and also for timing of various cardiac events. If the patient has an abnormal EKG or a normal EKG with borderline enzymes, if the patient presents with chest pain, obviously the next step would be to do some kind of a provocative test to see if we can show inducible myocardial ischemia. It could be a regular treadmill test, it could be a nuclear stress test, it could be a dobutamine stress echocardiography, or it could be a PET scan, or it could be an MRA. But anyway, so you get the picture. After that, if patients are having palpitations, we can order telemetry, and sometimes if we are seeing these patients in a clinic setup, we can order an event monitor, which can be from anywhere from 48 hours all the way up to 14 days. After we get all the initial blood works and all these things, then we make a decision as whether the patient needs medical treatment, whether the patient needs cardiac intervention like cardiac catheterization, or whether the patient needs a pacemaker, whatever the course may be based on the initial evaluation and the lab studies. And sometimes patients may have to go for surgery. And we have to put down our assessment, the major points. What is the main point you're focusing on? Chest pain, acute coronary syndrome, non-transmural myocardial infarction. That's the main thing. Then our plan would follow the acute coronary syndrome path. Or if the patient comes with heart failure, shortness of breath, decompensated systolic congestive heart failure, then our treatment plan goes along the heart failure route. And of course, you make your progress notes and you order the test for the next day. Whenever you see a cardiac patient, it is absolutely essential to make sure the patient is NPO after midnight on the day of admission. You may be saying, that's stupid. Why should everybody be NPO? And I'll tell you why. Because most of these patients are here for cardiac evaluation. A lot of these patients, based on their initial blood work, x-rays and EKGs, may need some kind of a test. It could be a stress test, it could be a stress echocardiography, or it could be cardiac catheterization. So make sure these patients are kept NPO until you make rounds in the morning and decide what is the next course of action. Because if they had something to eat, if they had caffeine, you cannot do the nuclear stress test that day. And if they had something to eat, you cannot do cardiac catheterization for 6 to 8 hours. So you need to pre-plan the hospital stay from the time you see the patient. That's an important point. I hope this quick summary has helped you to get a quick start on how to evaluate a cardiovascular patient and what tests to order and what treatments to begin based on their symptomatology and the clinical diagnosis. Acute coronary syndrome, palpitations and arrhythmias, or shortness of breath and worsening or decompensated heart failure. So you get the picture. I know you want to get a copy of this book. I tell you, you can get a copy of this book by sending me an email to drniknikam@gmail.com, and I will be happy to send you a copy of my book. If you would like to hear a video presentation on any other topic, I'll be more than happy to prepare that. We have more than 160 videos or 170 videos on our YouTube channel. You can watch them for free. And please do subscribe to our YouTube channel, and I will see you next time.